All right, so Dr. Rhodus is in my great pleasure to be here this morning. This is going to be a little bit different kind of a presentation because a lot of it's about pragmatic process and how to get things accomplished to a certain level anyways, by a good collaboration between a couple of schools at the university here, the dental school and here. So in putting this together, he's going to give part of this, I'm going to give part of this. I've known Nelson now for about 25 years. He's been the oral medicine person here at the university for both student teaching and for clinic. And his role in clinic was really, really important when we had all the transplant patients without good treatment for graft versus host disease. So he's been embedded in medicine the whole time. He's been embedded in dentistry as well. And we'll kind of go from there. I'll start out with a couple of things here that are kind of introductory for both of us. So our intent is to kind of review process of our translational clinic and how we developed it, discuss some of these collaborative processes, try to talk pragmatically about some of the system constraints, and then to discuss some of the things that we felt were very salient innovations that can be exported to other organ systems for cancer prevention and maybe even treatment. If we look at the history of the U of M cancer team, head and neck cancer team, and why I ended up coming here originally for residency 35 years ago, was because it served 4 hospital systems, both of our safety net hospitals. Our catchment realistically is about 3 million patients for our head and neck cancer team. And then for the actual referral clinic that Nelson and I established, we've gotten patients from 27 states. We have 14 surgical members of the team, and 7 of us are reconstructive surgeons. There's about 6 medical oncologists that service our patients, 7 radiation oncologists throughout the system, at least 6 dental school faculty, and about 20 other ancillary staff. Early highlights that are really important is B.J. Kennedy was considered one of the fathers of chemotherapy. So there were early chemo cases of series that we did here in the 1970s. There were 3 gentlemen, Jerome Hilger, Jack Duvall, and Theodore Grage, that did some of the first skull-based surgery in the world, was done here, at least in the United States. The first head and neck society president from the ENT side was Dr. Hilger. Theodore Grage was a plastic surgeon that did head and neck cancer resections, but he did randomized trials for unresectable cancer patients back even in the 70s. And then George Adams joined at that point in time as well. George Adams was why I kind of came here. He started organ preservation work and chemotherapy. He was he started one of the first multidisciplinary cancer care teams. I was a resident in '92 when we had our first meeting where all the services that treat patients were there. He led and performed key clinical trials. Some of them became gold standards. One of them had an early stopping rule. The only time there was ever a stopping rule in an ECOG trial for head and neck was the trial that he designed with the radiation therapist for nasopharynx cancer. And then the innovation that we're really here to talk about is the fact that we wanted to start an active surveillance and prevention program. And we've been able to lead or participate in most of the trials that have been offered since 2000 or so. Dr. Karawal and you have been in charge since then. We expanded from 3 faculty to 8, so that's made my life a lot easier from a surgical standpoint. We have comprehensive care at multiple sites throughout the whole region. And then our oral potentially malignant disease program is not just here with Dr. Rhodus, but also at Health Partners. There was a rationale for my hiring where I worked for about 40 years in inflammation and cancer as both a clinical researcher as well as a clinical trials and cancer researcher. It's been time at the NIH. So I was asked to start a translational lab by all the people who were my mentors here over the past, and they provided a K-like environment for me and Nelson to develop a clinic, and it protected maybe 15–20% of my time, but it resulted in almost no publications because we spent all our time trying to build cohorts and everything else like that. And I basically tried to do an oral medicine fellowship because ENT people don't do a lot of oral medicine, so we co-attended clinic for a couple of years so that I would get more experience in oral lesions. And then we do bench to bedside driven work. And then the protected time was a real important aspect of this. We set up the molecular oncology program. I set this up, and I wanted it to be a bidirectional translational program between the ENT clinic, this OPMD clinic that we have, and we were scattered between Phillips Wangenstein and elsewhere, and including Health Partners. And then we have this bench laboratory, and between all 3 things, we've managed multidisciplinary, interdisciplinary journal clubs for the better part of 25 years. And we've tried to bring in more collaborators as need be that we've kept for long periods of time. Our mission was really to create this oral potentially malignant disorders program. Again, it's a newer term from about 8 years ago. I still don't get it quite right every time, but we wanted to have the capacity to recall clinics for visits, because most oral pre-neoplasia visits were point of care visits. Oh, you don't have cancer, that's fine, just want to tell you that. And we wanted to really create a home for these people, because there was no home in really in the United States for this kind of a program at all. And these people do get cancer, and they get cancer at the rate of maybe an abnormal, colonoscopy or something along these lines, where there's just polyps there. We wanted to cross each other in oral cancer and head and neck cancer management, as well as the oral medicine stuff. And then we wanted to perform research ultimately to reduce the rate of cancer. And with that, I'm going to send off to Nelson here. He's going to talk about how he got involved with the team, and then we'll switch off again.
Thank you. Thank you so much, Frank, and good morning to everyone. Thank you for attending. So just going backwards just a tiny bit, as Frank mentioned, this is our silver anniversary, 25 years together. And so the gift will be coming later, Frank. But I just wanted to mention my start was pretty early, 1986. And my interest at that time, before actually the pre-neoplasia, pre-malignancy for oral cancer research began, was with Sjogren's syndrome. And kind of the segue here was that we were looking for particular biomarkers, and particularly biomarkers that would inform us of disease activity, like any condition that you would like to discover, some sort of biomarker that would let you know if this person is likely to progress in terms of their disease activity and complications from the condition. And like many conditions, there's a range of severity. Some people can have the condition and be relatively mild, where others can have major complications. And we know that. So that was trying to, part of our goal here. So you can see even years and years ago, preceding our relationship together, was trying to look at specific proteins that might, again, help inform this disease activity process. And we had this, what we would refer to now as pretty archaic method of trying to identify proteins, these 2-gel electrophoresis. And then going forward, when we actually started looking at saliva, and more specifically, the old ELISA techniques that when we look back today, they were pretty archaic. But what that led us to start to think about, again, is, why are certain individuals, in this case with Sjogren's syndrome, likely to progress to more severe conditions? So we thought, because Sjogren's involves exocrine gland pathology, and that exocrine gland pathology, again, can progress. So part of that is dry mouth, but we also thought that using saliva in these individuals, since the salivary glands are affected, could, again, give us those biomarkers that might inform us. And then, of course, came along with a very robust interdisciplinary team. So kind of a little segue to what Frank and I established with interdisciplinary team for oral cancer, was preceded a little bit by what we did with Sjogren's, and trying to engage people who were experts in proteomics and genomics, and of course, utilizing the gene microarray gene chips, and trying to determine, again, what maybe some of these specific genes and protein products would inform us about the activity. So here with Sjogren's, it was these interferon-related genes, and on the panel to the your right side of your screen, you can see that is indicating the disease activity. So this is both head and neck manifestations, but also systemic complications that some of these individuals get. And of course, some of those are the patients that are indicated by this more robust interferon signature. So, kind of lost our signal here, I think. I don't think I still have it on my screen, Joel, but not on. Must have touched something wrong.
Yep.
I'll just make sure I touch this.
Yeah, the space bar.
Okay, space bar. Okay, thank you. Sorry for the little interruption there. So again, part of that was with further investigation, a number of successful grants. We were able to actually determine more specifically, one of the major head and neck manifestations of people with Sjogren's syndrome is the development of lymphoma. And from a clinical standpoint, of course, this can be a very serious clinical complication that they have. And again, part of this was driven by discovery of these interferon-related genes that could inform us, identify the people that would be at higher risk for lymphoma. So again, at the end of the day, like any other condition that you might want to explore, vis-a-vis oral cancer, we could find a biomarker that would give us some indicator of the process. So this led me to beg the question of a major conundrum that we have in oral cavity cancer, and that is the oral cancer. The model is generally started by a non-malignant phenotype, again like other cancers, that have the potential to progress and transition to full squamous cell carcinoma. And part of the dilemma is identification. What do these patients look like? Of course, there are risk factors involved like tobacco and alcohol and that sort of thing. But the clinician has a difficult time discerning, what to do with a lesion like this. This type of lesion, a relatively small leukoplakia, white plaque, has only about a 5% conversion rate. But part of our clinical conundrum is which 5%, like the lymphoma patients. So anything that we could do to inform us of that potential of that lesion going to cancer would be very helpful. So leukoplakia, again, is kind of the recognized, documented precursor. So when we see that, we know that some of those leukoplakias, again, will eventually become cancer. And so very similar to like colon polyps or keratotic lesions on the skin, similar kind of transition model as the skin. Barrett's esophagus is another one of those inflammatory lesions. And I'll leave it at that because Frank is going to talk a little bit more about the whole inflammatory model for progression of oral cancer. So again, this is just an example of very early oral cancer, and obviously the intent of any sort of diagnostic protocol or any diagnostic adjunctive types of aids, for example, like biomarkers, would be to detect it at its very earliest stages. So one of the earliest stages of oral squamous cell carcinoma is, of course, invasion, abrogation through the lamina propria, and angiogenesis. So once, obviously, those early kind of post-epithelial mesenchymal translation of the lamina propria, and then development of angiogenic processes, of course, that's kind of a hallmark of the earliest tumor formation. So that was our goal, is to actually look at what could inform us of, sort of this critical linchpin of when that would occur. So having this, kind of fervor and passion about wanting to try to get earlier diagnosis, I went to Dr. Adams, and he was so fully supportive. And this is something that we needed to have. By and large, most of the activity in the otolaryngology section is taking care of people who already had advanced cancers. And being a tertiary care center here, we had tons of those patients coming in. So there really wasn't much time or resources to actually go backwards and look at, why they're, falling off the bridge to begin with. And so he said, Nelson, I have exactly the right situation for you, because I have this guy that's going to be coming from National Cancer Institute from training with Carter Van Ways, and that's Frank Ondrey, of course. So he said, I have the perfect match for you. So George was kind of our matchmaker and early on and supporter. At the same time, I realized that we had this huge repository of specimens in the School of Dentistry and Oral Pathology section, because most all of the pathology for oral cancer comes into the U. We're pretty much the only oral pathology readout center in the state and even surrounding states, the Dakotas and somewhat Wisconsin. And I went to my colleagues and said, can we develop a program of monitoring patients who have pre-malignant lesions, vis-a-vis, again, the dysplasia. And of course, they could identify those by the biopsies that they had in their oral pathology cohort. So I wrote a IRB protocol, and it gave us permission to access those specimens and to follow up with them with the surgeon who submitted them, and then also to recall those patients because, as Dr. Ondrey previously mentioned, prior to what we did here, there was really no way of monitoring the people who had these potentially malignant lesions. And it was more or less just left up to the physician or dentist who happened to notice a progression, or rarely the patient might notice a progression, but there was no real active, effective surveillance. So that was our goal, really, is to develop this protocol, get IRB approval, contact the individuals so that they could participate. Well, first of all, so we could study their specimens and involve their specimen, their histologic specimens, but then eventually it sort of morphed into the ability to recruit these patients for our clinical trials and so forth. And that, of course, helped to fuel it. So epithelial dysplasia, we could go back and look at those specimens again in their blocks or the actual slides, and they can be stratified again in levels of severity. So we can have mild, moderate, severe epithelial dysplasia. And of course, that means that some of those dysplasias will progress towards squamous cell carcinoma. And there's a little bit of a misnomer here because we don't really use carcinoma in situ any longer. But I think you can still get the concept that we go from this non-malignant but atypical set of cells to that kind of that fulcrum and that slippery slope going down to invasive squamous cell carcinoma. So obviously, again, our goal is to try to determine when is that going to happen? To whom is that going to happen? And because everybody who develops epithelial dysplasia does not get cancer. Probably worst case scenario is about 35% of those. So some do, some don't. Which is which? How can we identify those for better surveillance and, again, intervention so that they don't progress to full-fledged squamous cell carcinoma? So, and we did at this point in time have some ideas of the pathophysiologic or carcinogenic progression markers like loss of heterozygosity and alterations in tumor suppressor gene and some of those things, which again is kind of old history for what we know about cancer, but you have to look back and realize that this is like 1997 or 1998. And so again, the goal is to try to determine something that would be maybe less invasive, because a big conundrum that we always have in the clinic is when to biopsy. We know that we might need to intervene somehow, and that might include getting a tissue biopsy, but we're not going to biopsy every single lesion every single time the patient comes in. And realizing, again, that some of these will progress, we needed something that would be a very effective surveillance mechanism for the progression, but non-invasive. And of course, the whole goal today, we have about 65% or so of the patients who present with oral squamous cell carcinoma. The yellow represents that are in stage 3 or stage 4. And unfortunately, that's much less survival, of course, if they have more advanced cancer, stage 3 or 4, than if we discovered them in stage 1 or 2. So that's the whole idea here, is to reverse this process and have more individuals coming in for intervention that have earlier lesions, and of course, then better success in the outcomes. So the goal here, our ultimate vision, if you will, was not to replace a biopsy or other intervention, but really to inform us and inform clinicians. If you see this particular biomarker, then you know that this may be the earliest translation or transition of that condition to oral cancer. And of course, those markers would involve like pro-inflammatory, pro-angiogenic types of molecules. And again, eventually histology will be necessary, but getting to that point is the goal. So saliva, of course, is very readily available in the oral cavity. It is in the whole milieu of the microenvironment of whatever's happening. It could be periodontal disease, it could be an oral lesion like candidiasis or a canker sore. Viruses, we do see multiple types of viruses being expressed in saliva when you have an infection. So whatever is happening in the tissue in the oral cavity is going to be expressed in saliva. It just can't escape that environment. So readily accessible, multiple sampling is very easily, you can basically sample saliva every day with like a little Q-tip or a little pipette. And of course, it would be informative if we had a good, reliable biomarker. So again, enter the whole concept of having now this basis for going forward, kind of a platform, if you will, with specimens, with potential actual patients with these premalignant lesions that we could recall and bring back for surveillance. And now developing a more robust interdisciplinary team. So we have people from the medical school, from the dental school, from biochemistry, mass spec. So Tim Griffin, at this point in time, we engaged, Tim is the director of the mass spec center here now, but at this time he just arrived here from the University of Washington. So we were lucky to actually get him on board. And of course, then going forward, we're looking at specific protein biomarkers in the saliva that, again, might inform us. And indeed, what we were looking for, again, with this early indicators of transition from non-malignancy to malignancy would be angiogenesis. So our focus was to look at NF-kappa B dependent cytokines in saliva as an indicator of this process now going forward. So, obviously you can stratify by, normals, early dysplasia, late dysplasia, carcinoma, and look at those specific salivary pro-inflammatory cytokines. So that's what we did, and actually had quite a bit of success. And probably most importantly this was sort of the springboard for this interdisciplinary team to go forward with success in funding. And I think Frank has a slide on how many grants that we've been able to acquire after this, and then also publications and contributions to the scientific community on this whole process of carcinogenesis. So that's sort of part of the message that we want here, is just how things develop and how it's built, and kind of having a vision, and then things coming together with individuals who are really experts in their job. So now this is where we kind of are today. Maybe we're a little bit more advanced and having much more specific proteomic and genomic biomarkers for these conditions. Nothing really ready for prime time quite yet, but I think it's very promising and probably will be coming forward. So I'm going to just stop at this point, kind of giving my little interjection there, and invite Frank back to continue.
So we have slides about what we considered sort of salient kind of innovations for the whole process. So one thing that I learned from Nelson is that as a head and neck cancer surgeon, we're taking tobacco histories, alcohol histories on people, as well as sometimes with certain populations if they're chewing betel nuts or anything of that nature. But the other part of this was the other sort of lichen planus or lichenoid disorder associated risk factors. So I've expanded my history for these lesions that could sometimes be a little bit confusing to find out what kind of toothpaste people are using, what kind of dental amalgams. I performed maxillectomies, which is removing the roof of the mouth for people that have had dental amalgam go bad. And I've done that probably a dozen times over my career now. So these are the kind of things that even my predecessors, a guy like George Johnson said, I don't know why this person has cancer in their mouth, this or that or the other. And they don't smoke, they don't drink, what's going on? And it would turn out that they might have had a whole series of some kind of a dental amalgam that they reacted to in an inflammatory fashion that caused them to have surgery. So part of it's the expanded history taking. We really try to calibrate an examination for the mouth, which is very important for this type of thing. Nelson had his way of teaching and doing this in the dental world. We learn a certain way inside of our world, but we pay attention to things like the light temperature of the lighting that you're using to look at in a mouth will alter how much inflammation you think is there. So you want to be consistent about that. Everyone uses tongue blades. I don't use tongue blades. Nelson and I will use we'll wipe the lesion off one way or another. So I'm the only ENT guy in the department to probably use a boatload of Q-tips because I'm able to go in for an early lesion that might be converting to cancer. Oftentimes it's going to not be painful at all. It's going to be painless. But if I'm rubbing on that and I get some blood on my Q-tips, I know that there's some angiogenesis going on there for some reason clinically. So that's something that's going to concern me a little bit more during my examination. We do extended risk teaching. So we try to make our patients expert in their own condition so that if they have something go on and they don't have a clinic appointment for 3 months or 6 months or even a year, they always know that they should be able to call in and say, something's changed now. And we've often used that as when we do an intervention. Nelson and I, the one thing that we've concluded is that when there's a stable lesion and there's been some kind of a change that seems to be more malignant, that's when we biopsy or remove or anything else along those lines. There's a wide range of inflammation-associated treatments that are used. There's actually a Rhodus magic mouthwash that's out there that he concocted over his career that is often used by the group here at Health Partners and elsewhere to be able to go ahead and treat some of these conditions with topical anti-inflammatories. And then less invasive surveillance techniques. We have a paper coming out soon on oral cavity biopsy techniques and their safety, and other collection techniques. This hasn't been done before, but we feel that it's important to have that registered for our clinical trials because some people will be able to quote back that if we do a certain kind of a biopsy that we don't have CTCAE graded toxicities from the biopsy itself. So this is the sort of thing that we've done, and we're also able to risk stratify with repeated biopsy techniques at times when they're indicated. The other stuff that I think is kind of important here is a couple definitions. What's active surveillance? It's regularly monitoring a patient's condition to delay or avoid treatment. This is done in prostate cancer, thyroid cancer, breast cancer as well. So we have recall visits, history examination, and education. That's how we kind of run this thing that we've called an active surveillance program. Then there's an experimental part of this as well, where we'll do some kind of interventions like a brush biopsy or something along these lines, specimen techniques, maybe even diagnostic techniques. We've used things like the Visilite over the years, toluene chloride as a way of examining the mouth to try to act as a diagnostic adjunct. But the bottom line is that your physical exam of an experienced examiner is going to be better than the currently available adjuncts. And then the idea would be is that we want to alter disease course to predict or prevent cancer within the context of active surveillance. That's one of the other tenets of that. Oral potentially malignant disorder, newer term, and this is the NCI definition, but it's a group of conditions in which there are changes that might become cancer. We just sort of look at, is there a patch or a white lump or thickening like we showed in these slides? And but now it is included to expand all the cohorts of folks that we see. So I like using this term now because it's a very good catch-all term. And when using that catch-all term, there's about 4 or 5% of the whole population of the United States that harbors a risk for oral cancer at a higher level. First, there's all the leukoplakia variations, transplantation, graft versus host. We see a Fanconi anemia population, and then all the inflammatory and autoimmune diseases that can affect the mouth are precancerous at some level or potentially cancerous. So those people, when they have active disease, need to be under some level of surveillance. A paper that just came out this year in Journal of Clinical Oncology was a search done by some folks at the NIH as well as some prominent oral pathologists, where they examined the simple occurrence of tongue inflammation as a diagnosis within the whole Medicare database. And then they crossed that with all the oral cancers that developed in the same patients by doing this high-level technique to analyze things. And they found that if you have a previous diagnosis of mouth inflammation, tongue inflammation, that you're up to 25-fold risk of developing tongue cancer over time. And that's like more than tobacco even. So these kind of things are important, and they're, you know, new to a certain degree. And it remains interesting to me forever. The term of field effect or field cancerization, head and neck cancer, that's where it was coined, 1953, where once you're a heavy smoker, your mucosa is diseased. And if you get a cancer, you're up to 3 to 7% per year chance of getting additional cancers over time. And that's of the whole field. That could be the lung, that could be the bladder, that could be the mouth again, the esophagus. So we've developed this cancer active surveillance program. These are really referrals for OPMD. These they also included people who had OPMD that progressed to cancer. They're in a recall clinic. They're also for all the previously treated head and neck cancer patients who are at risk for second primaries, the Fanconi population, et cetera. And we've had some innovations in clinical trial cohorts when we've looked at some of our own data. We had a failure on an early chemo prevention trial to accrue. So we had to revamp an entire technique for trying to get patients onto clinical trial, but we did show a 130-fold increase in our accrual rate. We went from, it's kind of it's not fake news or anything, but we went from 2 or 3 patients out of 300 patients to getting 50% of the patients in the following trial onto a clinical trial. And we've had a screening database. And it's gone from about 100 patients that we first had in our practice, and now there's over 1,500 patients that are in this database in the state of Minnesota that we are part of a cleaning, that are part of this. It seems to be, we're the only screening program. There's a whole grant, a U grant system through the NCI called the Cancer Prevention Network. And we're the only institution, I think, that are in 2 of the chemo prevention consortiums, because we've had the ability to accrue to multiple organ sites based on the techniques that Nelson and I developed 20, 25 years ago. And we've had CBERs, N awards, 3 R01s or more. And I think a little bit is that our capacity to run through and the capacity to maybe have most of the most clinical trials of any of the NCI designated centers for prevention allowed us to get a really good score on our last renewal. Now, what we've been trying to do since about COVID for the last 4 or 5 years is we wanted to go ahead and start looking at some of the functions within the CTSA and cross that with my patient population. So we kind of wanted to do a quality assurance analysis to find appropriate catchment for our clinical trials. So what we did is we got 30 or so diagnostic codes, and we were able to run that through Fairview. And this is part of a R01 grant that I now have, so that we could have enrichment of screening for chemo prevention clinical trials that we have. And what we found is we wanted to find out certain things for our center here. So on the left-hand side here, and this was contributed by multiple medical students, on the left side here, we have the states where our program has contributed patients at different levels. As you can see in dark blue, it's mostly going to be Minnesota and Wisconsin and the Dakotas, but we have people that have come from California or other places, and this would be their permanent address, that their permanent zip code is where their mailing address. We were able to cross this. And then we want to see in the state of Minnesota where we're serving people appropriately or not. So as one might expect, you can tell that in the Twin Cities, we're seeing the majority of our patients, but in the whole Fairview catchment up through the Iron Range, we get an adequate number that represents our catchment of the Masonic Cancer Center. And then in the rural areas, we're a little bit lacking. It turns out that, let's see, I think I have one more. In the catchment findings, we do, however, in this, we do have a slight overrepresentation of African-American Black patients into our screening program, which you rarely see in any kind of a clinical trial circumstance or any kind of a clinic like this. And we're a little bit low for the Asian population. This is by race, not ethnicity. So then we have another component of this along the way has been the training and outreach that we do within the context of the program, within the context of our faculty positions. And we're cross-appointed at both the medical school and dental school. So we think that that was an innovation, because I could go to the dental school and teach, he'd come to medical school and teach, he'd come to all the clinics, wherever we basically have them, and just kind of show up, and for whatever reason, whether it's to give oral medicine talks or anything else like that. But that was very much an important thing. And to the extent that when we started working together, Nelson's knowledge on oral cancer compared to most dentists is really, really high. So he was on the American Dental Association task force, and he went around the whole midsection of the country for several years talking about oral cancer, oral screening, based on maybe 1 or 2 of the slides that was even presented here today. And the area that Nelson's been great with has been consensus building. he's able to go ahead and he's been at the university longer than I have. So he's able to be sort of a rainmaker to say, it's like, I know this person here. We're starting to do some microbiomics work in the carcinogenesis prevention program. And we need some folks at the dental school. And then Nelson was able to help us out that way too for new relationships for advancing the carcinogenesis chemo prevention program. One example would be the one-to-one outreach to trainees that both of us do. At this point in time, Nelson has trained over 6,000 dentists in the region, one-to-one for oral cavity examination for cancer. And that's really, really an impressive number over the years. I've had about 125 otolaryngology residents that I have 5 years at a time that I'll train about this type of thing. I've trained 8 mid-level providers that are doing a lot of screening for these types of things now at Health Partners and elsewhere. And in the Health Partners example, in 1999, we had a couple clinicians for a 300,000 patient catchment for the system. But as of 2024, on top of myself and a partner there, we have 7 surgeons, 6 mid-levels, and it's about a 1.5 million catchment. So we're serving that catchment with the kind of techniques that I learned from Nelson and with the sort of things that I've taught to my trainees, because a number of my partners are my trainees. That helps. And then I'm there on Thursdays. So a lot of the tough oral premalignancy or oral suspicious lesion patients are coming to 3 mid-level providers. And this is from the whole Health Partner system with 150 dentists. And if they have trouble with something for things that we haven't discussed much, they'll just bring me in the room. They just take me away from my 3 clinic chairs at the one end of the clinic, and they'll just bring me down and have me introduce me to other patients as to what to do next. The practice-based resource network here and at the it's a big NIDCR effort. We haven't interacted much, but we have done teachings with them. I think I've certainly given lectures to that. That's the whole midsection of the country that the practice-based research network goes. It's mostly for things like dental pain, but it includes oral cancer too. And we're basically a tertiary quaternary difficult disease referral center. So all of the easy stuff in the whole region that's able to be handled by people that I or Nelson have trained gets handled. So we get to things all over that are more difficult and more calcitrant. And that's why these patients are kind of coming from other states as well. Now, for clinical trial refinement, we started out with a celecoxib of industry trial as our first chemo prevention trial, but we're up to about our 7th clinical trial now that we've been the principal contributor to, and oftentimes ran these. And we have a new phase 2A trial that Beverly, our project manager, and I are starting for using diabetes drugs. And we started out just using pioglitazone from some preclinical work that I did. And now we're using metformin and pioglitazone together as dual chemo prevention in a phase 2A strategy that's taking off right kind of as we speak. Now, in terms of the pre-chemo prevention efforts, I came at this with the idea that oral cancers are often inflammatory disease and have been concentrated with not the destructive effects of tobacco on the genome, but more or less the contribution of tobacco and other types of conditions to the inflammatory milieu that these cancers live in. So we have these abnormalities that are genetic for certain, and then you're basically giving them all the fertilizer that they need to develop cancer. So we're still really looking for a holy grail for this. The heat map that's on the right side was from a Randy Shaver grant that we performed, where basically we went a centimeter away from a premalignant or early malignancy lesion. And when I did this work with Pat Gaffney at Oklahoma Medical Research Foundation, a former partner here, and he said this was one of the best segregating databases out there. So if we go ahead and look for P53 abnormalities or something like that with random biopsies or loss of phanerozygosity in the mouth, a smoker is going to have maybe the whole LOH profile anywhere in the oral cavity. But here we were able to show that when doing RNA bulk sequencing on small lesions, if we go just 1 centimeter away from that, we have a completely different profile. And we're in the midst of putting that together for publication now. And we're in the midst of bringing this on as a transcriptional genomics type grants for them as well before we do more. With that data, for our clinical trial, we're going to have about 150 RNA-seq bulk done as a portion of the clinical trial, which would almost constitute a definitive set of oral premalignancy for the whole field. Now, the premise for active surveillance is to show that things are not getting worse. In the clinic, it exists really in the ENT and dental clinics, Health Partners, Hennepin County Medical Center, and VA Medical Center. That's where we have all our partners. Over time, we've had about 6,000 suspicious lesion referrals. between Nelson and myself. And I've gotten probably about 2,500 tumor referrals for actual cancers, sometimes within the context of are these a premalignant lesion or not. So to try to handle this from a scientific perspective, we've had this 20 to 30 year IRB approved protocols to try to do all kinds of specimens that one may need. We don't get urine from folks, but we have saliva, blood, biopsy, tissues, whatever. We innovated some biopsy techniques so that we could go ahead and get a 2 millimeter piece of tissue from the mouth. Last week, we're trying to make organoids from this by sending it off to Columbia University. But before that, we were able to show that we have 100% RAN8 fidelity of our RNA. So we could basically do RNA bulk sequencing on anything from a person's mouth with basically 100% guarantee that it's going to be active, good protocol. And we've had NIH and industry support for a while as well. So in kind of an overall summary, our partnership and our way of bouncing things off of each other, despite limited time, and like when Dr. Adams died for 2 years, I had to give up almost all of my research because I had to take over his whole practice. So we've had these fits and stops along the way, and any of these systems certainly have those kinds of fits and stops, but we've managed to be able to get some decent things done for 25 years. We've had patients in clinical trials and molecular studies, and we've had about, to my count, it seems like there's about 25 manuscripts that we've done about our clinic in some way, shape, or form. And the papers have gotten about 3,300 or more citations so far. And now we're on our 7th clinical trial grant to try to see if we're going to be able to help folks out with oral preneoplasia. So it's a long road and it's hard to make progress, but it's because we did all that admin time early on and really worked hard at that to be able to get patients to come and see us. And that's something that is difficult to do, but we've been able to do this, and we are always happy to be a resource for anyone at the Cancer Center to try to have them use our template or advice about this, that, or the other. And I try to do that in my co-leader role over at Masonic as well. Let's see now. And we've had a lot of patient benefits. So this is something that's sort of ethereal because it's not really within the research realm. This teaching counseling function is really impressive. I have patients that come to me with more recent data than I've read on their conditions. And these are people who are standard sort of Minnesotans, but they're worried because they lost half their jaw from a condition where they never smoked, or they've lost both sides of their jaw from a condition where they never smoked. And my record now is I've had a patient who's a university patient for over 50 years with a condition called oral lichen planus. And she's in her 80s now. She remains with a severe oral lichen planus case. And she had 3 simultaneous malignancies last summer that I removed. And she's doing well now, but 3 at a time. And so this can be a very, very long-standing thing. And this cohort building that Nelson and I have done is now finally allowing us to look at 5, 10-year or more outcomes when grants for this kind of thing only last about 5 years. We have a visit frequency and procedures based on risk stratification. I'm calling it the Archibald protocol. We wrote a paper with Hunter Archibald was my resident, and at an international meeting recently, I went to one of the oral premalignant lesions talks, and they said, if you follow the Archibald protocol, what's right about the Archibald protocol? What's wrong about it? So it was kind of nice to have something published just a couple of years ago where they're referencing the sort of things that we've been doing as kind of almost a industry standard or something like that. And we're molecular cataloging patients now. If you look at head and neck cancer overall, in the state of Minnesota, we do 3 to 5% better than the rest of the country when you do a drill down on the statistics. And I really think that Nelson and George Adams, people down at Mayo like Dr. Carrie Olson, who I knew, that this ability to have informed patients come in is helping that to some degree. We've built this large cohort. It's about 6 times larger than the biggest cohort that's been studied. That was out of UCSF almost 40 years ago. We've been asked for our expertise to maybe consult on over 100 occasions with various entities at the federal government, ADA. Nelson was the president of the American Academy of Oral Medicine at the time that I was really kind of training with him in a way. But it kind of at least is able to state that what we're doing seems to have pretty good affirmation on a level that's just outside the university or outside of the city. We've run the most NCI trials in prevention for oral cancer in that portfolio at this point in time. It's about a 20-year-old portfolio, that 25-year-old portfolio that we've had. We are developing this simple way of trying to interrogate the Fairview patients that come into practitioners. And we've met with the SPECS program as well as our own program, because I'd like to see if the template that we've developed is exportable to other pre-malignancy conditions. We have our first paper going out on that shortly. And then we really kind of serve in a way cancer research training, cancer outreach and education functions, two of the things that are required by the NCI for our renewal. And in a very conservative fashion, if we look at the attendees at our lectures over the years and the people that we've personally trained, we've had at some level over 30,000 trainees and lecture attendings for the kind of work that we've had to do. Because when Nelson was with the ADA, it would be like the whole State Dentistry Association of Tennessee or Indiana or something. So you're getting hundreds of people at a time that are using the sort of, that are instructed on the sort of things that we've done that we think is a best practice for these conditions. And we've had 200 or more medical surgical trainees. And then we've had about 40 colleagues as well throughout the scientific support mechanism for our molecular oncology program that we have additionally. The challenges. It's really one of the few surveillance clinics in existence. So we kind of really don't know how we're doing. I suppose as we collect some of this data, little by little, it would be nice to be able to interrogate it to see it's like, oh yeah, this program's seeing more early stage cancers than show up in a clinic or this or that. We're not quite there yet, but we're able to go ahead and do that. We don't have a non-invasive test yet. We have this 1% per year cancer development basically of this cohort. How do you refine that so that maybe you're not seeing the other 99 patients as often and causing them problem if they have to come from Nebraska or something like that? And so the success metrics for what we do are kind of challenging because there's not really other people that are doing this kind of thing. And we want to just acknowledge, NADCR, NCI, Masonic, the Shaver Foundation, Fanconi Anemia Foundation. And we've gotten very good support at a high level from the departments from Masonic. Important collaborators have been the ones really for the proteomics work. Griffin, Jagtab, Carlos, who's passed away, Pat Gaffney was a very good partner. We did the first Affymetrix study on head and neck cancer specimens, and then Dr. Rohrer and Mike Myers as well. I retired. There's a picture of us from about, I'm wishing Nelson a happy 25th anniversary here. There's Katie Cole and Carol, who were kind of our clinical trial people when Beverly was coming on. And then Nelson and I are on the ends there when we all looked a heck of a lot younger. And then Nelson and I share a love for the Boundary Waters. So I was there. I take my chief residents on a retreat there once a year. So I got up on Saturday morning. I saw the nice fog lifting off of one of the lakes. So this is a sunrise on Homer Lake. And that was September 21st, so right around a month ago. So thanks a bunch. And we want to offer our services if we can for anything, and also be available for any questions that anyone has. Yeah.
Thank you. Just one quick comment. First of all, it might sound like we're sort of bragging about all of our accomplishments and that sort of thing. Not the purpose. I think at the very beginning, Frank mentioned that our purpose is really to help inform other investigators and clinicians on something that's successful and how we really have built these collaborations from, having a vision and then trying to put all this together. But I can't emphasize how much just collaborating, because I can remember those early days being in the lab by myself, the only guy doing 2D electrophoretic gels. And, you just can't really function that. And these days we don't have that problem as much because we do use interdisciplinary teams, but I can't emphasize how much is bringing in and listening to people and communicating with people. The other quick thing I wanted to mention is one of the last slides that Frank showed us. We don't have a non-invasive test yet, but I just want to mention, because I kind of concentrated on saliva, but we actually have innovated and developed and refining a couple of other techniques for oral specimen collection. And that includes a brush, which we actually kind of refined the current state of the art for what we use for brushing the tissue. And that's sort of like a pap smear. So that's the whole concept, is doing a pap smear on these lesions as well as the saliva. And then the other one is actually developing a little filter paper sort of thing that you can just dry the lesion, suspected lesion, and then put this little paper, filter paper, directly on the lesion, collecting some of the transudate. And of course, that's a little different from saliva. You don't have all this other schmutz in there that saliva has. You're more directly accumulating. So we're actually working on that now. And again, just to sort of show how the kind of the evolution of once you start sort of a process, you can continue to refine it to the point where hopefully it will be clinically utilized.
Yeah, perhaps this came across too self-aggrandizing. I hope not. But no, we've worked very hard on these sorts of things. And in a system where there aren't like large team science grants that are given by the university oftentimes or whatever, we've been able to manage and be able to go ahead and move things forward in the field to a certain degree. But there's still a long way to go.
I've got microphones for anyone with a question.
Thanks. That was a really great example of how you build a That was really a great example of how you build a multidisciplinary program. So thanks for presenting that. But as you probably know, there is a trend into pan-cancer screening with blood-based assays, particularly ctDNA, and trying to find those early mutations. Do you think that has any role in oral cancers? Or have you tried to do that?
You both comment on this. Yeah, so I think
to do that with your sort of.
Yeah, once things become, my guess is that like P53 or other sort of oncogenes and things of this nature, I think that the blood-based tests for these things that are like global smoking changes and all that will that stuff will show one way. I worry a little bit that our pre-malignant conditions that filter down from a couple of main diagnoses, but many diagnoses, and 10% of the oral cavity cancers do not have a identified, precursor lesion. 25% don't have an identified precursor lesion, and so I think that, as everything, these pan-cancer tests are always going to be used on invasive cancers. If there's someone that would want to use this on our cohort, I think it would be interesting, but I kind of wonder if the cancer versus non-cancer yes and no switch, how important that is, because we look at our RNA-seq data, and a centimeter away from the lesion, things are completely different. That's far different than what you see for P53 and whatnot. So I don't,
Yep. The only other comment I would make is, great question, is that we actually had, especially with the early chipping, the microarrays that we did, look at peripheral blood, biomarkers too, because obviously that could have a good indicator. But I think, as Frank mentioned, we're interested in getting it a little earlier. So I think if these, circulating markers are in peripheral blood, that may be a step a little further from this micro-invasive process. So if we can get this change before it gets into circulating blood, like vis-a-vis right at the site, then hopefully that would be even an earlier indicator.
Yeah, you kind of dilute out a lot of the noise that way potentially. And one example would be one area we've had some difficulty in the field at times is people will go out and get HPV testing, kind of just on their own and whatnot, by their dentist or whatever, and then I talked to the thought leaders on this sort of thing around the country. And so you have maybe 30 million people or more who might show up with a positive HPV oral test. Yet you might only have 10 or 20,000 people out of that 30 million that are going to show up with a cancer in a given year. So how do you effectively perform a screening cohort of those 30 million people when only a small fraction of them are going to be getting cancer? So the other thing about our work is that the higher risk things that we could see on a mouth exam. So it's not like trying to detect an occult gallbladder cancer or small pancreas cancer. It's a little bit different of a thing. I think that if we're able to go ahead and create good education and get vectorial transformation just from some kind of a screening procedure, all of a sudden, if you get some of those stage 3 cancers into stage 2, you've already made a bigger impact than radiation almost on head and neck cancer. So trying to get at this stuff with earlier detection, I think is the right way to go. But the problem is that anyone who's a head and neck cancer surgeon might have a patient a month or a patient every 3 months that had nothing and they go to a stage 4 disease. I've had that happen about half a dozen times a year. I'll get like an old lichen planus patient that's 6 months out from their lichen planus patient. They need to have a major, lip or buccal resection or something. So, cancer is not predictable. There's a tumor progression model. A lot of times it takes a long time, but in oral cancers, once they convert, the kinetics of the growth are up to 1 to 2% per day is the growth rate. So it's felt that we want to treat an oral cancer within 30 days or 40 days of its diagnosis, because there's a chance that it could upstage to the next stage up in just a month and a half period of time. I don't know that would be the same for, breast or other cancers. So oral cancer is both a deadly and deforming disease, but it's also kind of like a rapidly growing disease sometimes too.
So a related question to that last point. So for all of the specimens you have in your bank, how are you following patients to see if they progress to invasive malignancy?
Yeah, so we haven't had the capacity to have sort of like I know that for the longest time there was the Iowa Nurses Public Health Cohort at the public health school where they had decades of program grants or something to follow these folks along. So we follow them along visit by visit based on the stratification of their level of risk. There are times when I've had people who are like, they're an oral leukoplakia patient and they have a circumstance where they wanted a thing removed. I have a patient next week or two that I'm going to take out a mouth lesion. At that point in time, I'll follow him for follow-up. He's a transplant patient, so he's at high risk. But in his particular case, he's well educated and he's been in my clinic for about 10 years. He'll know how to monitor himself for that. So our capacity to monitor and biopsy, some of it's based on the clinical follow-up of these patients, and some of it is based on the when they get pathologic diagnosis, how risky that pathology is. Because the other problem is with this particular field is that removing dysplastic lesions does not alter whether or not someone's going to get oral cancer. That's a big problem, a huge problem for this field. It always has been there. We don't have a way around that.
We've got a question on from our virtual audience. Hupin Chu asks, can you comment on the potential of optical screening methods such as optical coherence tomography?
Yeah, that's a perfect question actually. So there's OCT, there is the autofluorescence that's been used. So the earliest OCTs were very interesting because they were done with archaeological OCT things that looked for disturbances at the level of the surface. So they looked to see, oh, is this surface abnormality enough to go to the next level? It's something that was used for like, I don't know, fossils or something. So that's rapidly developing. MD Anderson and Gillenwater works with Rice University on a variety of techniques, because it would be great if these could be deployable with some kind of a simple camera system or a cell phone to the areas that have a high endemic oral cavity cancers. We have not done any OCT trials. I'd certainly welcome if there was someone at the engineering school that wanted to do this. We certainly have the patients to lend for a study like that. We could do it at every level of cancer plus every level of pre-cancer. But we haven't. But I think it's promising. But it's I don't think there's any FDA approved devices for that yet. Yeah.
Any other questions in the room?
I might just comment about that too, because we have actually explored, Frank mentioned this previously, about some of these technologies that are light-based. So, essentially it's that sometimes these microflores in the tissue can fluoresce and under certain wavelengths based on what's happening with the tissue. So this is kind of emerging technology to just put a little light in, and if the tissue reacts in a certain way to that, visualizing that light, that might indicate kind of the progression. So far, as he mentioned, this hasn't really been shown enough success, but what we've noticed is it gets the clinicians thinking about it. It gets the clinic, because if they use this little light, the light may really do very little, but at least we know that they're looking at this lesion and following it and perhaps maybe making the proper referral. So it's kind of almost a failure of a device, but yet a success in terms of the outcome.
And the other thing that could make this field difficult is that in head and neck cancer, it's only 3 to 5% of all the overall malignancies. So when you look at where you're able to do large scale innovations or clinical trials, it's always going to be in breast or colon or prostate and those sorts of areas. And it's always kind of lagged behind for some of these other malignancies that are, that have not shown as much of a cure rate approval as they really should over the course of our careers.
All right, well, thank you very much for a great talk on very good shared resource type stuff. So thank you.
Thank you.